Hello, everyone. Thank you for joining us today for our webinar entitled MACRA, MIPS, and APMs, Exploring the New Quality Payment Program. Today's presenter is Bruce Mackey, MCEDA Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Bruce, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will also be posting a recording of today's presentation on our website, mceda.org. A copy of today's slides are available there now by going to www.mceda.org. Hover on the Resources tab and then select Webinars. Also, the presentation slides are currently available in the Handouts section of your GoToWebinar interface. The information you will hear in this broadcast is current as of today and is only intended to be a general summary. Since Medicare and Medicaid policies change frequently, the best way to stay up to date on current requirements is to review the actual written law or regulations. We encourage participants to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their content. Today we will start out by giving you a brief overview of MCEDA and our various service offerings. Following that, Bruce will take over and provide you with an overview of the new Quality Payment Program, followed by some information on what you can and should be doing right now to participate in 2017. Following the presentation, Bruce will take time to answer any questions posed by the attendees. Housed within Alterum Institute, we are MCEDA, the Michigan Center for Effective IT Adoption. Originally born out of ARA, and more specifically the HITECH Act, MCEDA is Michigan's regional extension center, tasked by the federal and state governments with accelerating the selection, adoption, and meaningful use of health information technology to improve the quality and efficiency of healthcare in our state. To date, we have assisted nearly 6,000 providers across Michigan, impacting 1.6 million patients annually. Ranked as the 5th largest REC out of a national network of 62, we are also funded by the state of Michigan to assist any provider participating in the Michigan Medicaid EHR incentive program. MCEDA's health IT services include the following. Number 1, meaningful use support at any stage in the year. Providers participating in the Medicaid EHR incentive program also benefit greatly by qualifying for state-subsidized services that bring our highly rated technical assistance to you for only $200 per provider, a savings of 96% compared to commercial service rates. Number 2, security risk assessment and network security evaluation. Risk assessment is an embedded service within our meaningful use support. But if providers only need assistance with the SRA, for example, to satisfy the requirements of the new Quality Payment Program, we offer it separately as a standalone service. The network security evaluation process is quick, simple, and with our tools and expertise, your technical security will be evaluated against known vulnerabilities. Contact us for more information. Number 3, attestation and audit preparation. If you are getting ready to attest and just need some peace of mind that you've crossed all the T's and dotted all the I's, or if you're one of the many folks who have been selected for an audit and need assistance responding, we are here to help. Number 4, consulting services. With our broad range of consulting experience, we can provide hands-on performance improvement assistance with common pain points, such as patient flow, productivity, efficiency, and staff and patient satisfaction. Call today for a quote for services. Number 5, the Great Lakes Practice Transformation Network offers no-cost technical assistance to eligible providers in support of quality improvement initiatives and preparing for upcoming advanced payment model changes under the new Quality Payment Program. Number 6, our chronic care management program enables physicians to take advantage of the recently updated Medicare billing requirements for CCM services. We provide you with a dedicated care manager who works within your practice, helping fulfill CMS criteria to maximize your reimbursement potential. Contact us to learn more. And number 7, funded by the Centers for Medicare and Medicaid Services, the Quality Payment Program Resource Center for the Midwest provides free help to clinicians in small practices and rural or underserved areas as they navigate participation in the CMS Quality Payment Program. Go to www.qppresourcecenter.com to join today. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you everybody for joining us today to learn more about MACRA and more specifically the Quality Payment Program, or MIPS. So we'll start off here by showing you a glossary of acronyms. I go through quite a few acronyms. If you've been in healthcare for any amount of time, you know that we like to talk in alphabet soup. So this will help you if I hit an acronym that you are unfamiliar with. I do want to just reiterate what Liz already mentioned. You can pick up these slides already from the MCEDA website. Also, if you go to the GoToWebinar interface, you will see 2 versions of these slides that I'm going through today. There is the full slide version, and then I also posted the 3-slide handout with notes. And feel free to grab either or both if you would like. So let's start off by talking about MACRA. So what is it? It is the Medicare Access and CHIP Reauthorization Act of 2015. It is strongly bipartisan legislation that really can happen with today's Congress. I bring that up because it had tremendous support on both sides of the aisle in Congress. I say that because if anyone is hoping that this gets blown out of the water, that is probably not going to happen. I think the future of meaningful use could potentially be suspect, but I think MACRA is here to stay. And to be honest, we'd really want it to stay. It replaced the flawed SGR, or sustainable growth rate, that was plaguing us for years. And with this new formula, by paying clinicians for the value and quality of care they provide, we most definitely don't want anything like the SGR to come back. So I think MACRA is a good change from that, and it is most definitely here to stay. It's a lot more predictable than the SGR as well. It's going to increase the number of physicians that are participating in something called alternative payment models, or APMs, with those in high quality, efficient practices benefiting financially under this new model. I'll talk a lot more about what APMs are as we get deeper into this presentation. As the name would suggest, MACRA also extends funding for the Children's Health Insurance Program, the CHIP program, for an additional 2 years. And the main thing that it brings to us, and what we are discussing today, is the Quality Payment Program. It's part of this broader push from CMS towards paying for value and quality. It really boils down to getting away from fee-for-service payments. That is the primary goal. We need to shrink the number of providers that are being paid strictly under fee-for-service and start moving them towards this new model that really starts to pay for value and quality. And we start to see reimbursement levels shift and change depending on the amount of value and quality that you are providing to your patients. There are some embedded goals towards kind of shrinking that fee-for-service model. We are well on track to hitting and exceeding. We also have a number of strategic goals that are attached to the Quality Payment Program. The QPP is looking to improve beneficiary outcomes, enhance the clinician experience, increase the adoption of something called advanced APMs, and I'll talk about what those are. We're trying to maximize that participation, improve data and information sharing, and ensure the operational excellence in program implementation. All worthy goals. Hopefully the QPP is able to hit all of them. Draw your attention to this quick tip at the bottom here. You see that website down in the lower right-hand corner, qpp.cms.gov. That is an excellent website that CMS has set up devoted to the Quality Payment Program. There is a wealth of information there, great tip sheets, specification sheets, really a kind of a sort of a one-stop shop for a lot of what you're going to need, and really everything that I will be talking about today, and quite a bit more is reflected there. All right, so we'll take a look at kind of a conceptual MACRA diagram. This is as simple kind of representation of MACRA that I can give you. We've got MACRA at the very top. There was a lot of other regulatory changes embedded within MACRA that I am not talking about today. we are focusing strictly on the QPP, or the Quality Payment Program. And then within the QPP, there are two different paths that you can choose to participate in. We have the Merit-Based Incentive Payment System, or MIPS, and as path 1, and then path 2, we have the Alternative Payment Models, or APMs. And then within APMs, there are a few different categories of them, two of which we'll be focusing on today. We have advanced APMs, that's kind of the gold standard. The ultimate goal here of the QPP is to drive as many clinicians into advanced APMs as possible. For now, anyway, the majority of providers are going to be in path 1 under the MIPS. Or they're going to be kind of bridging the gap here because they are not in an advanced APM, they're in a non-advanced APM, otherwise known as MIPS APMs under this model. So there's sort of a middle ground between path 1 and path 2 where you find yourself in some sort of APM, but you're still participating in the MIPS path as well. So I will talk about these two paths now in much greater detail, starting off with path 1 of the QPP, the Merit-Based Incentive Payment System, or MIPS. So what is MIPS? It combines multiple Medicare Part B programs that you are all familiar with into a single program. It takes the Medicare EHR Incentive Program, or the Meaningful Use, Medicare Meaningful Use, and I'll pause here and point out that this is only the Medicare Meaningful Use Program. MACRA does not alter or end the Medicaid EHR Incentive Program, which is alive and well in our state. It is on track to continue through the year 2021. If you have at least claimed the very first incentive payment, that's what's known as the AIU, or Adopt, Implement, or Upgrade payment, by the 2016 program year, you are still eligible to continue collecting attesting to Medicaid meaningful use and collecting those incentives through 2021. There are 6 incentives total, and I highly encourage you to stay on that path as well. There's some great crossover between Medicaid meaningful use and one of the performance categories here that I'll talk about in a moment, but they are separate programs requiring separate attestations. So participating in MIPS does not mean you are also participating in Medicaid meaningful use, and vice versa. If you are in Medicaid meaningful use and attesting there, you have to attest separately to this program. There's no two birds, one stone kind of effect here with these two programs. They are parallel. Okay, so it takes the Medicare EHR Incentive Program. It takes the PQRS, or Physician Quality Reporting System, that's been around for, I think, more than a decade at this point. It takes the Value-Based Payment Modifier. It adds a 4th category called Improvement Activities and combines all 4 of those into this new program called MIPS. So we have 4 MIPS performance categories in this new program. We have the Quality Performance category, which is formerly the legacy PQRS and the Value Modifier, or the quality side of the Value Modifier. There is the Cost Performance category, which is formerly the cost program, or the cost side of the Value Modifier program. There's the category 3, performance category 3 is the ACI, or Advancing Care Information Performance category. This is formerly the Medicare Meaningful Use. So meaningful use is, the components of meaningful use are still a part of this new program, but we've changed the name to ACI, or Advancing Care Information. And we have Improvement Activities, or IA. This is a new category that they're bringing in new for this new MIPS program. So who's eligible under the Merit-Based Incentive Payment System? In years 1 and 2 it is defined, and it's a very limited list. It's going to exclude some participants that were folks that were previously participating in the PQRS program. So it is only these 6 provider types that are eligible to participate in years 1 and 2 of the program. We have our MDs and DOs, your physician assistants, nurse practitioners, your certified nurse specialists, and the registered nurse anesthetists. Always a tough word for me to say. So we have those 6 provider types. That is set in stone. Those are the only 6 that can participate in years 1 and 2. In years 3 and beyond, we will see CMS expand the list to broaden it, start to include a lot of other provider types. We do not yet know all of the provider types that will be eligible. This is a guess at this point. but there are a lot of other provider types. Some of these were previously participating in the PQRS program, so they have already been used to submitting some of that quality data. They are now kind of off the hook, where they don't have to participate anyway. There are ways to still include their data if you're group reporting, which I'll talk about more in a moment. But for now, they are not eligible clinicians in this new program. In years 3 and beyond, we will see that list expand, but we'll have to wait to get that list finalized by CMS through some future legislation. I already threw out this new term, eligible clinician. I just want to point out also that under the legacy programs, the people that were participating in the program were known as eligible professionals, or EPs, both in PQRS and meaningful use. That term has now been replaced with EC, or eligible clinician. So let's look at the other side of the coin then. Who is exempt from MIPS participation? So we've got 3 different categories of folks that are exempt from participating. They cannot or do not participate this year. We have first-year Medicare Part B participation providers. So if you are a new physician or you're newly credentialed to be a Medicare provider, you are off the hook for MIPS. You cannot participate in this first year. We also have the low volume threshold, and this is where the category where we will see the majority of providers be exempt under these different categories. The low volume threshold is Medicare allowable billing charges less than or equal to $30,000 or provides care for 100 or fewer Medicare patients in 1 year. So what does that mean? So we've got 2 different qualifiers here. We've got that the Medicare allowable billing charges of $30,000 and needing to provide care for 100 or more patients in 1 year. So if both of those conditions are true for you, meaning in phase 1 of the dates you see here on the screen in front of you, if both of those are true, that you have your Medicare allowable billing charges are greater than $30,000 and you have provided care to more than 100 Medicare patients, then you are a MIPS provider. You are over that low volume threshold. If either one of those conditions is not true for you, then you are exempt. You cannot participate in MIPS in this first year. So both have to be true to be into the program. If either one of them is not true, you are exempt in this first year. And then the other category of providers we have are those certain participants in the advanced alternative payment models. And I'll talk a little bit more about what that means to be in advanced APM. But if you are participating in one of the few advanced APMs available today, then you are also exempt from participating in the MIPS program. The MIPS also does not apply to hospitals or facilities. So there's a couple of different ways that you can participate in this program. One way is as an individual. So every NPI and tax ID combination is looked at separately in this program. So if you are a provider that is working for more than one organization, you do not combine your performance across those organizations. Each tax ID and NPI, that combination is looked at as a separate entity within this program. So that is one way to do it, just as an individual. You can also band together and form a group. So a group is 2 or more clinicians who have reassigned their billing rights to a single tax ID number. So you could look at your entire practice of clinicians and decide to form a group. If you do that, you're going to be assessed across all of those performance categories that we touched on. Together, you're going to kind of aggregate that data for each of those performance categories across your entire group and provide one set of data to CMS. Also, if you are part of an ACO, if you're in an APM entity, meaning one way would be through an ACO. If you're in an ACO, you are locked into that group reporting under that alternative payment model. And I'll talk a little bit more about that as well. So individual reporting or group reporting. So what you're shooting for here to participate in MIPS is the MIPS final score. Those 4 performance categories, you're going to get an individual score in each of those categories. That individual score gets consolidated into this MIPS final score. There are different weights, and I'll touch upon what those weights are in this first year in just a moment on the next slide. But that final score can be anywhere from 0 to 100 points. You want to get as close to 100 as possible. That gets you the most financial impacts, and certainly indicates that you are providing high quality and high value in your care as well. So we've got those 4 performance categories we've touched on: the quality category, the cost category, improvement activities, and the advancing care information category. So the weights this year are a little different than what we're going to see in future years as well. 2017 is a transition year. CMS had to pull back a little bit and give some flexibility in the scoring model for this year to kind of ease us into this new MIPS program. So in the scoring model, again, we've got that 100-point system that's going to increase and consolidate the financial impact. It ranks peers nationally and reports scores publicly on the CMS Physician Compare website. So that's something that's very important aspect to keep in mind, that whatever your MIPS final score is, whether you're participating as an individual or a group, that score is going to be publicly available on the Physician Compare website. In 2017, you can see the vast majority, a full 85% is coming out of 2 of those performance categories, the quality and the ACI performance category, because the resource use is not going to be used in this first year. So in 2017, we only have 3 of the performance categories that are in play. That is set for 2017. It is likely to also be the case in 2018. There's a proposed rule out right now that we'll see finalized later this year that I think is likely to set things in stone with keeping the cost or resource use category at 0 in 2018 as well. But we're going to see cost being used in future years. And so we've got that layout. We've got 15% or points for your improvement activities, 25% or 25 points comes from the ACI, and 60 points or 60% comes out of the quality category. As part of that transition year, we also have something called Pick Your Pace. So again, CMS had to provide some flexibility in the program in this first year, and they've made it really extremely easy to avoid the payment penalty that's associated with this program. So if you choose not to participate, meaning you are a MIPS provider, you're over that low volume threshold, it's not your first year of Medicare participation, so you find yourself being a MIPS provider. If you choose not to participate, which I hope none of you do, you can bank on getting a negative 4% payment adjustment. So in 2 years from now, in 2019, you're going to lose 4% of your Medicare Part B reimbursements. Don't do that. Please don't do that. It is very simple to get at least into the Submit Something bin here. So under Submit Something, which will only negate your payment penalty, it'll keep your current reimbursement rate at 0, or not at 0, but there'll be no adjustment to it. It's very simple to at least do this. If you're under the Test or Submit Something bucket, you are submitting a minimum amount of information from 2017 to Medicare. For example, it could be a single quality measure or 1 improvement activity. You could do the base side of the ACI performance category. If you do just that one thing, you can avoid that downward payment adjustment in 2019. You could literally put 1 G code on 1 claim in 2017, and that would be enough. So that's why I say, please do not pick the don't participate if you are a MIPS provider. At least do the Submit Something, where you're giving a minimum amount of information to CMS. It's a few minutes of work to get to that first bucket, and it's going to mean avoiding that payment penalty in 2019. The majority of folks, and hopefully really all of you, are going to be in either the Submit a Partial Year or Submit a Full Year bucket. So under Submitting a Partial Year, you're going to submit at least 90 days of data from in any 1 to 3 of those performance categories. So you don't even have to submit under all 3 of those performance categories to get a modest bump in your Medicare reimbursements. So under that partial, you are submitting in either the quality, the ACI category, or the improvement activities category, or all 3 of them for a minimum of 90 days. If you do that, you're in that Submit a Partial Year category, you will get a MIPS final score, and that final score will then be used to figure out your Medicare reimbursement rate in 2019. Hopefully, the majority of you will take that next step and submit for a full year. So a full year, that's full participation. You're submitting 365 days worth of data across all of those performance categories. I think if you do that, if you're kind of working the numbers to figure out how to get the best score, you're going to maximize those Medicare reimbursements. And really, you can be anywhere from 90 days to 365 days, and you're really kind of fully participating at that point. As long as you are submitting anywhere from 90 to 365 days in the calendar year across all three of the performance categories that we're using in this first year, I think you're going to maximize the financial potential under this program. And that total financial impact then is going to depend on how much data you submit and what those performance results are. So how do you get that data to CMS? There's a lot of different ways to do that. There's several submission options available to you, both as individuals or if you're submitting as a group. On the quality side, this really matters. I'm going to stress this several times, especially as we get deeper into the how to participate in 2017. Your data submission under the quality category could make a massive difference in your MIPS final score. And I'll talk about what that means as we get a little bit deeper. But under the quality performance category, data submission option is possibly one of the most important decisions that you can make. As you can see, there are several different options available to you. Under the improvement activities and the advancing care information, the data is the data, and the way that you get that data to CMS isn't going to affect your score like the quality category does. So just pick the ones that you're capable of doing, the ones that's easiest for you, maybe the ones that are cheapest. Some of these options may charge a fee. There is an attestation website coming that you would be able to attest the improvement activities and the advancing care information categories. That's going to be free. Other ones, there may be costs involved. You'll just have to work through those different submission options to figure out which ones you're capable of using and which ones are the best ones to be using. I've got the submission methods are defined here if you're unfamiliar with what each of those are from the previous screen. I'm not going to go through all of these, just including this for your own reference. So what does it mean when you have participating in MIPS? What are the incentives and penalties? So as was the case under the old legacy programs of PQRS and meaningful use, the adjustments are applied 2 years after the performance year. So we are in the 2017 performance year now, and that is going to affect your 2019 reimbursement rates. The program is budget neutral. So this is kind of a new aspect that we have not seen previously in the legacy programs. The providers that are receiving the negative adjustments are paying for those that are receiving positive adjustments. So if you end up getting hit with a penalty, just know the practice down the street is going to benefit from that. So don't be on that side of the coin. It is a linear adjustment based on that MIPS final score as compared to the set performance threshold for that year. So in the first year, that performance threshold is a whopping 3. So what that means is, in terms of that MIPS final score, I mentioned that it goes anywhere from 0 to 100 points. If you at least score 3 points, you will not get hit with a reimbursement penalty. That's where in the pick your pace options, where it's really, really simple to negate that payment penalty in that first year, because it's really easy to get 3 out of 100 points. Doesn't take much. You could send in one quality measure, and you're going to at least get a 3 for that. It doesn't even matter how bad the quality is reflected in that quality measure. The lowest you can get is 3 points on one quality measure, and that's where the performance threshold is. So it's a linear adjustment, though. So depending on what your final score is, that adjustment, hopefully a positive adjustment, is going to be somewhere between 0 and what was supposed to be 4% in the first year. Because of the pick your pace options and this budget neutrality, we're not going to see the top end be that what was projected to be 4%. It's probably going to be a lot less than that, 0.7, 0.9. We don't really know what the top end reimbursement bump is going to be until we see how many folks choose to do nothing and take that penalty. You don't want to be in the bottom 25% of total performers, though, in this program. If you do find yourself in that bottom quartile, you will automatically be adjusted down to the maximum penalty for that program or payment year. In this first year, that is 4%. So if you choose to do nothing, you're going to get, you can guarantee you're going to get hit with a 4% penalty for this first year. Then the higher scores receive proportionally higher incentive payments. And to maintain that budget neutrality, there's something called the 3 times modifier that's been built in. So we won't see this in use really in the first year, again, because of the pick your pace options, and because CMS has made it so easy to avoid that penalty in the first year. Also with that low performance threshold of only three, and with it being so easy to get over that, we know that there's not going to be this big pile of money to split on the top side. But in future years, when it's a much higher performance threshold that you're all shooting for, to maintain that budget neutrality, we could see that top end reimbursement bump get modified up to 3 times. So what would have been a 4% bump in a normal year could go as much as 12%. And then just like those in the bottom quartile are getting hit with that maximum penalty, there's some additional incentives for the best performers in the program too. So if you find yourself in the top 25% of performers in MIPS, you will be eligible for up to an additional 10% bump in your Medicare reimbursements with something called the exceptional performance bonus. Again, I don't know how well we'll see this in use in this first year. We'll just kind of have to wait and see. But as we get deeper into this program, we could see eligible clinicians receiving a 37% increase on their Medicare Part B reimbursements by the year 2024. That's by taking the top end adjustment, multiplying it by that 3 times modifier, and then adding that additional 10% for the exceptional performance bonus. So we could see those best performers getting a whopping 37% increase on Medicare reimbursements. That could easily equate to millions of dollars extra on the bottom line. So this kind of summarizes those incentives and penalties, a lot of what we just talked about. In the middle, we see that performance threshold. That's going to be adjusted from year to year. This first year, it is a whopping 3 points. We're waiting to see what it finalizes as for year 2. It could be around 13 points, I think, is what they're proposing. So we'll likely see it increase a little bit for next year. By year 3, it becomes the average or mean of the prior performance. So the average of everybody else's prior performance in the prior year. So CMS is going to set that performance threshold for us in years 1 and 2. And then after year 3, it really becomes a race to the bottom. You are literally competing against the guy sitting next to you in the practice down the street and that other hospital system. You need to be performing better than they are across these performance thresholds, or you could see your Medicare reimbursements take a hit. So you don't want to be below that performance threshold. If you do, you're in that red. If you're in that lowest 25%, you're going to get hit with that maximum reduction, and you can see what those percentages are going to be over time. In the first year, it's 4%, then it goes to 5, goes to 7, and then it tops out at 9. Top side is the same. This is where you want to be. You want to be in the green. You want to be above that performance threshold to maximize or maintain those Medicare reimbursements. As long as you're above that performance threshold, you should see your reimbursement rate be adjusted somewhere, anywhere from that 0 to 4%. Again, because of the pick your pace options, we're not going to see that top end be at 4% in this first year. It's probably going to be around 0.9, 0.7. So still a modest bump, but as the program gets deeper, we can see that increase. We'll start to realize that up to a 9% increase. And then you want to be, hopefully you're in that additional performance threshold. Those top 25% performers will get to split up that additional up to a 10% bump. That they've set aside an additional $500 million each year for the additional performance threshold. So that's one side of the coin. We'll take a look at path 2, the alternative payment models path, more specifically the advanced APM path, is the other fork in the quality of payment program. So what are APMs? Alternative payment model is a generic term that describes a payment model in which providers take responsibility for cost and quality performance and have their payments adjusted depending on those scores. So according to MACRA, APMs in general include the Medicare Shared Savings, ACOs, and it's really all ACOs. If you're in any type of ACO at all, that is an APM. We have demonstrations under the Healthcare Quality Demonstration Program, CMS Innovation Center models, and then other demonstrations required by federal law. When you see the term APM or alternative payment model, you can equate that to mean ACO or medical home. So medical homes are a type of APMs. ACOs, all ACOs are a type of APM, and that's really the majority of APMs that we see out there are ACOs and the medical home models. There are a lot of other value-based reimbursement models that also qualify as types of APMs, but for the most part, when you see APMs, think ACO or medical home. So MACRA is not going to change how any particular APM pays for the medical care and rewards that value. The QPP really builds on top of that. It's going to add some additional incentives to the existing model. So whatever the shared savings that you're getting or you're on the hook for through your ACO, that stays in place. Then the QPP kind of builds on top of that and provides some additional reward for you for being a high performer. APM participants that are also participating in MIPS, I talked about that when we're at that rudimentary diagram a few slides ago, where you could kind of be bridging the gap between being in an APM, but you also have to participate in MIPS. If you find yourself being one of those providers, and there are a lot of you out there, you're still going to receive some sort of favorable scoring under certain MIPS performance categories because you are in an ACO, any type of ACO. If you're in an advanced APM, that's really the gold standard, though. That's where you have that other MIPS exemption. So if you're in that advanced APM, there's not a lot of advanced APM options. I'll talk about what those are, but really a small subset of APMs are advanced APMs. So we'll talk about the different types of APMs here. I'm going to start at the bottom of this pyramid here with the MIPS APMs. So I just talked about that. If you're in a MIPS APM, you're going to receive some favorable MIPS scoring. That's really going to benefit you and allow you to get a decent MIPS score because you're in that MIPS APM. This is the vast majority of ACOs out there are MIPS APMs. Medicare Shared Savings Track 1, which makes up, I think, close to 90% of the CMS or the Medicare ACOs that are out there, those are MIPS APMs. So Track 1 ACOs are MIPS APMs. They are not advanced APMs. So you still have to participate in the MIPS program if you're in a MIPS APM, but you get that great favorable MIPS scoring. Provides you some kind of freebies, as it were, towards building that MIPS final score. Next, we have qualified medical homes. They must be expanded under CMS authority. They really have a different risk structure that's built into them, but they're otherwise treated as advanced APMs. I think the only one we have out there right now that would kind of fall in this middle ground is the CPC Plus program. So that is a medical home model, but it does qualify as an advanced APM. And really, what does it mean to be an advanced APM? It honestly comes down to the amount of risk. If there is enough risk built into the APM's model or the ACO's model, where if you do not perform well or the group doesn't perform well, you start to lose some payments and have to pay back CMS because you're not demonstrating enough value or quality. If there's enough risk built into that APM or that ACO's model, that is an advanced APM. So it really comes down to the amount of risk. And these advanced APMs offer the greatest risk, but they also offer the greatest potential for reward as well. So that's the gold standard that we're ultimately trying to push providers to in this model, is to get into those advanced APMs. So what are the incentives then for being an advanced APM? Well, I talked about how the model design really stays in place. The QPP does not change those shared savings that are a part of it. You got those flexible payment bundles, other desirable features. Every ACO is different, or every advanced APM is very different in that regard. So whatever that contract is you have with that ACO, let's say, that qualifies as the advanced APM, that does not change. It's going to build on top of that. How does it build on top of that? It's with a 5% lump sum bonus. So if you are one of the eligible clinicians that's significantly participating in an advanced APM from the years 2019 to 2024, you're going to get a 5% lump sum bonus on top of your Medicare Part B payments. So what that means is, looking at the 2017 program year, if you are in an advanced APM and you are a qualifier, I won't touch too much on what it means to be QP status or qualified participant status. CMS has already told us that really all advanced APMs are on track for their members to reach QP status, so it's sort of a non-issue this first year. It's going to be more of an issue later in the program, but for this first year, we're expecting all advanced APM participants to reach that QP status. As long as you reach that qualified participant status in 2017, 2018 becomes your measurement year, 2019 is the payment year. So in 2018, CMS will look at your individual Medicare Part B reimbursements, whatever that is for that whole calendar year of 2018, and then in early 2019, you will get a 5% lump sum bonus on top of what you billed out in 2018. So that's the additional incentive that's built on top of your advanced APM's current structure. You also get some higher reimbursement updates. So we're going to see the Medicare fee schedule lock in place after a couple of years. It's still going to get a slight bump for, I think, through 2019. After that, it's going to lock in place, and the only way to get your reimbursement rate to shift is by participating in the MIPS program. But later, as of 2026, we'll start to see the Medicare reimbursement rates, that fee schedule, get some modest bumps. And depending on whether you are in an advanced APM or not, that bump will be different. So if you're a participant in an advanced APM, it's going to go up 0.75% per year versus 0.25%. So there's that additional incentive for being part of an advanced APM. You get that higher reimbursement rate. And as I already mentioned, you get that MIPS exemption. So anyone that is in that advanced APM, you do not have to participate in MIPS. And it's because those models, those ACOs or medical home models that qualify include their own, they sort of include their own MIPS components. They require EHR use. There's quality reporting regardless. So because of that, you have that MIPS exemption. So there's not a lot of current advanced APM options out there. You can see them on the screen here. For the most part, in the state of Michigan, we've got Medicare Shared Savings Tracks 2 and 3. We've got a lot of CPC Plus providers out there, and there's some next generation ACO models as well. There's also the Oncology Care Track model, or Oncology Care Model Track 2, and the Comprehensive ESRD Care Model that qualify. We are going to see this list expand probably significantly in the coming years. It is continually being updated. There are a lot of ACOs out there that are trying to reach that advanced APM status for their members. So we will see this list expand significantly. If you want to keep up to date on that list, go to the qpp.cms.gov website. If you go to the resource library, there is a continually updated list of advanced APMs. So kind of summarizing a lot of what we just talked about in the timeline, we've got the fee schedule that's going to lock in place as of 2019. Then we'll see it start to adjust as of 2026, depending on if you're an advanced APM or not. We've got that MIPS track in the middle with those 4 performance categories. We see what those reimbursements are. And then we've got that other path to the APM path, or really the advanced APM path, where if you're a qualified participant, you get that 5% lump sum bonus, and you're excluded from the MIPS program. All right, we're going to cruise through the preparing for 2017 MIPS participation. There's a lot of things you can or should be working on right now, such as determining your eligibility and understanding those requirements, choosing whether you want to submit data as an individual or as part of a group. You need to be choosing those submission methods and verifying the capabilities, especially when it comes to the quality category. I cannot stress that enough. You're going to verify your EHR vendor or registry's capabilities before your chosen reporting periods. You're going to prepare to participate by reviewing that practice readiness, your ability to report, and then choosing what pick your pace option are you going for. Are you just going to do that minimum to try and negate that payment penalty, or are you going to go for the best MIPS final score you can? Choosing measures is a big part of it, especially when it comes down to the quality side. you need to be focusing all of your attention, or the majority of your attention, on the quality performance category. It is worth the most and has the most variation here. You can visit the qpp.cms.gov website. You can also visit our website, the QPP Resource Center for the Midwest, for some valuable measure selection resources. You can verify the information you need to report successfully, care for those patients, record that data, and then early next year, you're going to submit that data to CMS. I'm going to go through each one of these in a little more detail on the following slides, and as time allows anyway. So that first one, determining your eligibility. You could do this by calculating your own annual patient count and billing amounts for the 2017 transition year. You can look at that claims data to see where you fall in that date range there. Looking at whether you crossed that low volume threshold. Did you bill more than $30,000 to Medicare Part B and provide care to more than 100 Medicare patients in that measurement year? If the answer is yes, you are eligible and you must participate in order to protect your reimbursement rate. If the answer is no, that one or both of those qualifiers is not true for you, then you're exempt and you do not have to participate in this first year. The easier way to go about this is just to, you can go to the CMS website and look there. CMS sent some letters between April and May to each practice, each Medicare practice, detailing the providers that they think are associated with your practice to let you know whether they are MIPS providers or not. We know some of those letters didn't get to the person making these decisions. They're sometimes hard to find. You cannot get a copy of that letter. It's been very difficult to get at that information. But thankfully, if you go to that qpp.cms.gov website, right on the home page, on the right-hand side, there is an eligibility check. So you can go there, put in each individual NPI of your providers, and it will give you all of the information you need to know relative to 2017 participation. The added bonus to looking here as opposed to what CMS sent in those letters is they have some important special status information. You can determine whether you are a hospital-based provider, if you're non-patient facing. So some special status information is very important. That was not included on those letters, but you can pick up that information from the CMS website there. You're going to choose to submit data as an individual or as a group. There is no easy decision here. Really, ultimately, you have to crunch the numbers. There's no way to tell today, unless you have all of the data you're going to use, on whether it is best to stay and individually report or form a group and participate as a group this year. You just got to perform that detailed analysis to determine which option is best. Again, no easy answer. You've got to crunch the numbers. There's a lot of different factors that need to be considered to make that determination. What's your tax ID structure? What's that organizational structure, and how does that play into things? What kind of technology is available? Are you part of a multi-specialty group, or are you a member of an ACO? If you're in an ACO, you're locked into group participation under the ACO. If you're a multi-specialty group, it might not make sense to group report. Because when it comes to quality, if you've got multiple specialties within your group, it's going to be really hard to find 6 quality measures that are going to apply well to your entire group because you've got multiple specialties there. So you may find that it's better to individually report because individually you could get each provider can get a better MIPS score, which will then provide a better reimbursement bump. Your past performance and legacy programs can be used here to help you figure that out as well. But again, there's no easy answer. You got to look at it both ways and figure out what's going to provide the biggest reimbursement bump in 2019 and go with that. If you're submitting as an individual, as I mentioned, each tax ID and NPI combination is looked at as a separate MIPS entity. But if you are forming a group, then it's all those eligible clinicians under that single tax ID number are going to collectively submit their data across all of the MIPS performance categories. And then whatever the group score is, applies to each individual provider within that group. Choosing your submission methods and verifying the capabilities is probably one of the most important things you can do. I know this takes people by surprise, but it is a significantly important decision under the quality performance category. I'll talk about that and kind of what that means. So within the quality category, you are taking each one of those quality measures, and whatever your score is on that quality measure is being compared to a benchmark. And the benchmark is the average performance on these measures in the past. Depending on how you perform against that benchmark, that determines your score for that quality measure. Your score is going to be, for each individual quality measure, is going to be anywhere from 3 to 10 points. Each submission method has its own benchmark. So, and they vary greatly. So what might be a great quality score compared against the EHR submission method benchmark could be a terrible quality score when it comes to claims-based reporting or registry reporting or the CMS group interface reporting. So you need to look at that submission method. It is a vital decision to be made, because what looks like a great score when you look at a particular quality measure might not be when you compare against the benchmark that is set for that submission method. Sometimes you have to get, if anything below, let's say 3 to 7 points, or what is a low quality score, is of course going to give you a low score for that measure. And oftentimes with some of these, especially the topped out measures, you have to get almost perfect quality to get anything other than like a 3. So, but that might not be the case if you switch submission methods, because that benchmark changes for each submission method. You want to maximize your quality score by picking the submission method that's going to equate to the best MIPS final score. So I cannot stress that enough. Really pay attention to those submission methods. You could also speak to your specialty society about options. A lot of specialty societies have registries, some qualified registries or QCDRs that they're a part of, so that could assist you with these submission options. And so that could be a good way. You want to consider using a technical assistance program. There's several of them out there. We're all subsidized by CMS to assist you in this. The QPP SIRS right there is that website, the QPPresourcecenter.com. That is our support for the QPP. You can interface with us at that website if you are part of a small practice, meaning 15 or fewer clinicians under your tax ID number. You could join the QPP SIRS program at that resource center. We can assist you with helping you choose the different submission methods there. We've got a great tool that just came live that's integrated into that website called MIPScast. It is a MIPS scoring tool that can really help you with the decision of which quality measures to choose, as well as which submission method is going to give you the best quality score. And then you can visit the qpp.cms.gov information for great information also on the different submission methods, as well as the different support options out there. So you're going to choose that data submission option then, like as I mentioned, a lot of different options to choose from, and this is a very, very important decision to be made. So you're going to prepare to participate from there. You consider that practice readiness. Have you previously participated in a quality reporting program? You can, that might help you through that practice readiness. You're going to evaluate your ability to report. What is your data submission method? Is your system ready to be able to allow that kind of participation? Are you prepared to begin reporting that data early next year? You're going to review those pick your pace options that I've talked about for this transition year. You're going to hopefully at least do the test option where you're submitting that minimum amount of information that's going to negate that 4% penalty. Hopefully you're going to choose to at least hit the partial option where you're submitting under 1 to 3 of the performance categories for that minimum of 90 days. And then you can go to that full year where you're participating, you're submitting across all 3 categories for the entire calendar year. There's a good chance you'll find that that is going to give you the best MIPS score. But again, you just have to kind of crunch the numbers and determine what's the best reporting period that's going to give you that best MIPS final score. No easy answer there. You just got to get your data, start playing with it, start doing the math. So you're going to choose those measures and activities. This is probably one of the other most important decisions you can make, especially when it comes to the quality category. It has the most variation between picking those quality measures and picking the best submission method, probably the two most important decisions you can make, and then also determining whether you're going to submit as an individual or as a group. To me, top three decisions. But you're going to choose those measures. You can go to the qpp.cms.gov website or to ours, the QPP Resource Center. There's some great information there that can help you choose those measures. At the QPPCMS.gov website, click on the Explore Measures tab that's at the top, and then you can select the performance category of interest. Go to that quality measures one. There is some great information there relative to the quality measures. There are specialty measure sets that can help you if you are in a specialty. There's 271 quality measures to choose from. It can be very hard to determine which ones are most clinically relevant to you. There are specialty measure sets at the website here at that quality measures under the Explore Measures tab that can really assist you in that. And again, working with us at the QPPResourceCenter.com, we can help you with making those decisions as well. You're going to review the individual quality and advancing care information measures and specifications, as well as improvement activities. Wealth of information at these two websites to assist you in that regard. So you're going to, again, under choosing the measures and activities, you're going to consider the following: your patient population and the clinical conditions that you treat. Look at those practice improvement goals when you're selecting your improvement activities. You look at the quality data that you might be submitting to other payers. Again, there's a lot of value-based reimbursement programs out there that you might already be participating in. It's great to look at those if you're already focusing on those quality measures. If they're available to you under the MIPS, I would highly recommend you don't pick different quality measures for all the different programs. Try and consolidate that just to reduce your reporting burden. And focus on the quality measures that are most important to you, to your patient population, and the ones that can maybe be used across multiple programs. If you participated in one of the legacy programs in the past, consider those current codes. You can pick up some of the past resource use, or the quality resource use report. So there's a lot of data out there, even on your past performance, that can help you with that quality measure decision-making process. You're going to verify the information you need to report. Cannot stress enough, once you select those quality measures, really examine the data that you're seeing come out of those quality measures. We see a lot of issues in the technology that essentially break the quality measures. There are EHR issues, there are vendor issues, there's mapping behind the scenes that might be a problem. You really need to be taking the time now to look at those quality measures and ensure that they are measuring accurately. Again, we see a lot of problems, a lot of errors, some of them by no fault of your own. Others, your providers are not documenting appropriately. So you need to be looking at those numerators and denominators. And if a patient appears in the denominator and not in the numerator, figure out why. It might not be that the provider is not providing the best quality of care. It could just be a technical issue that's doing that. So you need to figure out those technical issues now and ensure that your quality measures are calculating the way that they're supposed to. You don't want to take a hit on your Medicare reimbursements because of a technical issue. That would be terrible. Submit that data. You're going to care for those patients. Data submission starts after the first of the year, goes through March 31st. If you're relying on somebody else to submit data on your behalf, don't trust them. Seek that confirmation of data submission. Make them prove to you that the data got to CMS. There are a lot of things that can happen, flukes in the system, whatever it can be. Again, you don't want to take a penalty in your Medicare reimbursement. If you've done everything you were supposed to and you performed really, really well, and CMS just didn't get that data by March 31st. So seek that confirmation. Some concluding thoughts. We're in the beginning stages of long overdue payment reform here. Just like we saw with the Meaningful Use program kind of shifting year to year, we're going to continue to see the QPP shift and adjust and get better and better over time. So what the QPP looks like today is not going to be what it looks like next year. We're going to continue to see it evolve. The long-term goal, as I mentioned, is to get as many providers into advanced APMs. That is not going to be the case starting out. Most of you are going to be in the MIPS program. But there is a significant potential here, especially in the high performers, as well as on the downside. We could see a 46% difference between the highest and lowest performers as we get deeper into this program. I got to believe that's going to make or break a practice right there. If the practice down the street is getting 46% more on their Medicare Part B reimbursements than you are. Also, don't forget about the current rules. The legacy programs that have been replaced, we're still dealing with the reimbursements or penalties through the end of next year on those before we switch over to however you performed in the Medicaid or in the MIPS program. We've got some resources for you here. Ours at the top. Please, if you are in a practice of 15 or fewer clinicians in your TIN, sign up for the QPP Resource Center. It's to your benefit. It is free. It will get you to a team of subject matter experts that you can bounce questions off of. It gives you access to the MIPScast tool that just went live in that system, that scoring tool that can take all of your MIPS data and give you a projected MIPS score so you can see how you're going to do. The second one there, the qpp.cms.gov, fantastic website that CMS has put out, wealth of information. Between those top two resources, you can really get at all the information you could possibly need, as well as resources for questions. And then everything else I've covered, you can pick up through the rest of these resources as well. And with that, I have, looks like I'm a minute or two over. Not too many questions. If you have any questions, please feel free to put them into the questions box of your GoToWebinar interface. If I don't get to any of your questions, I will answer you via email. You can also email me or call me at any time. I'm happy to answer any questions you have on the quality payment program. So 2 questions have come in right here at the last minute. Can you pick different submission methods for quality? So in year 1, no. So within each performance category, you can only choose one submission method. That is just the case for 2017. So unfortunately, in the quality category, you can only choose a single submission method for all of the quality measures that you are going to submit. You can choose different submission methods between performance categories. So you could pick a submission method for quality, you can pick a different submission method for your ACI, you can pick a different submission method for your improvement activities, but within each performance category, you can only choose one submission method. We are likely to see that change for year 2. I know that is very problematic, especially in terms of the quality category, because certain measures can only be submitted by certain submission methods. It's really confusing. Please give us a call. We'd happy to help you work through all of that tangled mess. But for year 1, quality, you can only choose a single submission method. In year 2, we should see that expand and allow different ones. Only other question I have today is, does the Blue Cross Blue Shield of Michigan PGIP program qualify as an advanced APM? No, it does not. I think that would qualify as some sort of APM, but that would not be an advanced APM, at least not yet. All right, I am out of time right now. Again, if you have any additional questions, please ping me. You got my email address, you got my phone. You can go to our website. We'd be happy to help you work through the tangled mess of the QPP. We want to ensure that you have all the information that you can, that you're making those smart decisions when it comes to your quality measures, when it comes to your submission methods. Please give us a call. We'd be happy to help in any way, shape, or form that we can. And thank you all for joining me today to go through this. I look forward to seeing you again on future webinars. You can stay up to date on all of our webinar offerings at www.mcita.org. And thank you again. Hope to see you again soon.